Thank you very much. The next treatment is the radiopeptide therapy, or peptide radioreceptor therapy also called. I'm going to show you an overview of radiopharmaceuticals, clinical indications, practical aspects, outcome, and the toxicity after radiopeptide therapy. Internal radiotherapy, it is an internal radiotherapy by using radio-labeled somatostatin analogs, which we can target the somatostatin receptors. Here I show you this figure. It is a neuroendocrine tumor. Of the tumor membrane, you have a lot of somatostatin receptors, and you can use a radionuclide with a chelator peptide, and you can bind to the receptor, and it is also a targeted therapy. You can radiate the tumor very targeted. There are 5 different somatostatin receptors, and we have an enhanced expression of somatostatin receptors on neuroendocrine compared to neuroendocrine tumors compared to normal tissues. We have different radionuclides like yttrium-90 and lutetium-177, which we use them for the treatment, and some other radionuclides like indium-111 or technetium, which we use for the diagnostic, different peptides like octreotide, octreotide, and finally, at the moment, different radionuclides for the treatment like yttrium-90 DOTATOC or lutetium-177 DOTATATE. Here, I'd like to show you the differences between yttrium-90 and lutetium. As you see here, different half-lives. Lutetium has a longer half-life, but the energy of lutetium is less than yttrium-90, and therefore, at the moment, lutetium is the best treatment option for the treatment of neuroendocrine tumors, longer half-life, less energy, less penetration rate, and there you can do the more targeted therapy with less side effects, especially renal side effects. The major NET groups are gastroenteropancreatic neuroendocrine tumors like carcinoid tumors, endocrine pancreatic tumors, medullary thyroid carcinoma, and also chromaffin tumors like pheochromocytoma and neuroblastoma. The indications for a PRRT for unresectable neuroendocrine tumors, for progressive and or symptomatic neuroendocrine tumors as a palliative treatment. And it is very important, we have to have a positive somatostatin imaging prior to the treatment. We have different possibilities. You can use SPECT or scintigraphy with octreotide, indium octreotide, or technetium high-nectok for the scintigraphy, but the best option is gallium-68 DOTATOC PET-CT with a better sensitivity and also resolution. The contraindications for a radiopeptide therapy: a Canofsky index under 40%, a markedly reduced renal function, also reduced creatinine clearance, markedly reduced bone marrow function, and a negative somatostatin receptor imaging. I'm going to focus on lutetium therapy, treatment with lutetium DOTATOC, because it is the best option there's, at the moment. We use in our department a dose of 7.4 gigabecquerel per cycle. We perform 3 to 4 cycles in 3-month intervals. 30 minutes prior to application of lutetium DOTATOC, we start with nephroprotection, a mix of lysine and arginine we use, up to 6 hours after the application of lutetium, and the lutetium is applied during 10 to 30 minutes. You have to monitor the patients, especially laboratory workup after 2, 4, 6, and 12 weeks, tumor markers every 3 or 6 months, chromogranin A, NSE, and specific hormones if present. And also renal function should be tested, and in patients with renal insufficiency or decreased renal function, you can perform technetium DTPA scan for the GFR measurement or technetium a MAX3 clearance measurement. Also, the radiologic response should be tested using RECIST criteria by CT or MRI imaging, and somatostatin receptor imaging is a part of follow-up of these patients. Now, how are the results? Here, a very nice study published by Klinikumbonn. They evaluated the toxicity of radiopeptide therapy in 504 patients, and also efficacy analysis they performed in 310 patients, and they showed a complete response in 2%, partial response in 28%, stable disease in 35%, and progressive disease in 20%. Better responses in pancreatic neuroendocrine tumors than carcinoids. Disease-specific survival was 11 months for progressive disease, but more than 48 months for stable disease or partial remission. And I show you here the Kaplan-Meier curve. You see here there was no big difference between patients who showed a stable disease, partial response, or a minor response, but a big difference between patients with, who showed progressive disease. And it is the case with neuroendocrine tumors. Stable disease is also a very good response, not comparable, for example, with lung cancer or other aggressive cancers. The neuroendocrine tumor is a slow vaccine cancer, and therefore, if you if you catch a stable disease, is also very good results. Bodi from Italy also performed lutetium therapy for patients with neuroendocrine tumors. They achieved complete response in 2%, partial response in 27%, minor 26%, stable in 27%, and progressive disease in 18%. And regarding quality of life, Khan showed in 265 patients that the quality of life significantly improved in 36% of the patients, and specific symptoms improved in 44 to 77%. As I mentioned before, we perform sequential treatments, and therefore you can follow the patient sequentially. Here, a peritherapeutic scan in a patient with pancreatic neuroendocrine tumors. It is the reference liver metastasis. 3 months after the first radiopeptide therapy, and actually before the second radiopeptide therapy, you see here a partial response, and 3 months after the second radiopeptide therapy, a very good response. Another example in a patient with a Ki-67, about 20%. It is a proliferation rate, and it means it's a grade 2, grade 3 disease with neuroendocrine tumors. The patients had a history of progression under biotherapy and also previous chemotherapies. With this huge liver mass, we performed 4 cycles of radiopeptide therapy, and you see here very good response after 4 cycles radiopeptide therapy. The Ki-67 index is very important. A lot of colleagues tell always Ki-67 should be under 10% or maximally 15% for radiopeptide therapy. We did this study some years ago, and we showed regarding treatment response, not overall survival or progression-free survival, just regarding treatment response, you can't see any significant difference between a Ki-67 of 5% or 20%, but more than 20%, you don't have a very good response after radiopeptide. What is with advanced grade 1-2 gastroendopancreatic NET? It is a newly published study from our group. A total of 232 radiopeptide therapy courses were performed for 68 patients. We achieved a partial response in 60%, minor response 12%, stable disease 13%, and progressive disease 14%. The median progression-free survival was 34 months, and the median overall survival was 53 months. And a G1, grade 1 proliferation status was associated with longer progression-free survival and overall survival in the multivariate analysis. And the variables linked to impaired overall survival were a reduced Karnofsky score prior to first therapy, a high hepatic tumor burden, more than 25%, and an elevated plasma level of NSE more than 15. My next topic will be the bone metastasis. Patients with neuroendocrine tumor and bone metastasis have a poor prognosis, and we treated 42 patients with bone metastasis, and as you see here, the progression-free survival was 35 months after 4-cycle radiopeptide therapy, and the median overall survival was also very good, 51 months. The pain palliation achieved completely in 55% of the patients and partially in 45% of the patients. And we published again this study with more patients this year, with 68 patients. And as you see here, two factors were very important regarding overall survival. One of them was the NSE, and other one Ki-67 index with a cutoff of 10%. One example from this study, a patient with midgut neuroendocrine tumors, after 4-cycle treatment, you see a partial response with a progression-free survival about 34 months. Another example, a disseminated bone metastasis from renal neuroendocrine tumors after 4-cycle, a complete response, no metastasis. You can use also radiopeptide therapy as a neoadjuvant for downsizing. Here's a case report from our group. You see here a patient with a pancreatic neuroendocrine tumor with infiltration, the adjacent organs, therefore the patient was not operable. The patient had also 2 small liver metastases. We performed 4 cycles of radiopeptide therapy, and after this 4 cycle, you see here a good tumor shrinkage, and the patient was operated after 4 cycles. It was 2011. Last week, the doctor of this patient called me and told me that the patient showed again a progress. It means actually 3 years progression-free survival after operation. Could we use radiopeptide therapy as a salvage PRRT? It means patients who had received 4-cycle PRRT and after progress again. Could we use PRRT? We treated 33 patients with metastatic gastropancreatic neuroendocrine tumors, underwent a total of 79 courses. All patients had initially responded to the PRRT. The mean cumulative activity was 44 gigabecquerel, and as you see here, the median progression-free survival was 13 months from the start of salvage treatment, and median progression-free survival after initial PRRT was 22 months, complete response in 1 patient, partial response in 6, and stable disease in 14 patients. And it was very interesting, patients with a history of a durable progression-free survival after lasting progression, after initial PRRT tended to have long-lasting progression-free survival after salvage treatment. Now about the toxicity, there are some acute toxicity, but actually they are not dangerous, like nausea, vomiting, abdominal pain in 10%, and hormonal crisis on the 2%, subacute side effects, but there are some serious and delayed side effects like renal impairment, especially if you use yttrium-90, and severe hepatic toxicity, but it's very seldom, and myelodysplastic syndrome is also seldom. Here, regarding nephrotoxicity, as you see here with lutetium, the possibility is under 1%, but with yttrium is about 9% renal toxicity. Now the take-home message. Radiopeptide therapy is one of the most efficacious systemic therapy for inoperable neuroendocrine tumors. You achieve an objective response. The quality of life is increased after the radiopeptide therapy. It's well tolerated. Serious toxicity is rare, especially if you use lutetium, and is an essential modality in the multidisciplinary management of neuroendocrine tumor patients. Thank you.